Hello, colleagues and friends, rhinoplasty lovers from all over the world. Thank you so much for everybody for being here tonight. For me, it's such a huge pleasure to be here again. First of all, Happy New Year. I hope everybody that have an amazing year this year because I have a lot of plans and we are responsible for what happens in our lives. We're responsible for what happens in our future. We can build it if we plan, if we focus, and that's the point. Okay, the mindset in our life, the mindset in our surgeries, and thanks again for everybody for being here. So today, it's a huge pleasure for me to talk about hybrid rhinoplasty in this live broadcasting. Um, First, I'd like to say that this was something surprising and something amazing for us because last year we started with Reno from A to Z, and what was kind of course that we imagined it would be like a basic course um, turned out to be one of the huge success in our platform, one of our best courses, and one of the courses that people were asking during all the year when was the next group. So thank you so much for being here. Today I separated a very beautiful surgery to show to you all the maneuvers from the beginning to the end. Okay, not to uh, I tried to separate all the important steps for you. So I really hope that you enjoy. Um, well, in this lesson, I'm going to show you how to master yourself in hybrid rhinoplasty, even if you're starting from the beginning. Okay, I know here we have uh, masters in rhinoplasty. I know here we have residents, we have medical students, we have people from all levels in rhinoplasty. So I separated something that even if you are not an experienced surgeon in rhinoplasty, you can understand and you can learn something from here and take um, part of the knowledge and put in your practice. Well, and at the end, I'm going to open exclusively today the registrations enrollments for the new Rhino from A to Z. Okay, as I said, our biggest success since we started almost 4 years ago. So, who am I? For those who don't know, who am I? I'm Dr. Fernando Nakamura. I I dedicate my life in my profession to rhinoplasty, and we created amazing programs so far on the last almost 4 years. The mentoring, the HRAM, our one of the biggest or the biggest cadaver dissection in hybrid rhinoplasty in Miami every year, and the Rhino HZ, and among other courses. And we have already helped more than 1,500 surgeons all over the world, more than 34 countries. So here's what you learned today. We're going to perform here an open rhinoplasty. I separate an open rhinoplasty because I think it's easier for you to understand and to see what I'm doing. I'm going to perform a dorsal preservation, but on this surgery, I can explain to you also how would it be if I was performing in spare roof A or spare roof B. So I use it the same case to show you the different possibilities. So one of the things that is very important, if you are a rhinoplasty surgeon, probably you do structure on the doors and you open the roof, you do spreader grafts, and it's amazing. But if you are interested in dorsal preservation or hybrid rhinoplasty, I'm going to explain to you how can you do your transition from the structural rhinoplasty to dorsal preservation, which I think it's one of the most important steps for those who are trying to incorporate dorsal preservation in your practice. Septoplasty, it's not so common for plastic surgeons, maybe more common for ENTs, but not for plastic surgeons to perform it. And tip treatment, tip plasty, using the concepts of the puzzle tip plasty. And at the end, we're open for questions and I'm going to answer all of you. So why this class is important for you? First, because reliable information is crucial to prevent complications. Every doctor are concerned about complications. So quality information helps you to prevent complications. And offering good quality of services, good quality of techniques to your patients is amazing for you to grow in the field of rhinoplasty and offer the best for your patients. Proper training and preparation are the key to safety and success in any rhinoplasty. Everybody knows that. And the importance of managing expectations well is essential to avoid unsatisfactory results and complications, as you already know. Well, this class is for you if you're seeking to refine your rhinoplasty techniques and achieve better results in your practice. Okay, if you want to be a specialist in rhinoplasty and you want to put yourself in the market in your city or in your country, if you wish to stay updated with the latest advancements in rhinoplasty, I think that nowadays, if you dedicate yourself to rhinoplasty, you really have to understand and you really have to incorporate some preservation concepts in your practice. You cannot do all your surgeries without these concepts nowadays if you are looking forward to be a specialist in rhinoplasty. And if you want to improve your skills and gain confidence in performing rhinoplasty, and if you want to attract more patients and increase the success of your procedures, and of course, increase your income and evolve in your surgery. We have some important rules here. Like anything, it's not magic, okay? It's discipline, technique, evolution, and knowledge. Okay, it's not a magical method here. It does not replace clinical experience, does not guarantee immediate results, of course, and does not eliminate the need for you to update yourself. So now I'm going to show the live broadcast of a complete hybrid approach for rhinoplasty. And remember that at the end, I'm going to open the slots for the 2024 Rhino from A to Z. Okay, it's going to be a pleasure to be with you, and let's start our surgery.
So we're going to analyze this case because this is the patient that we're going to perform the rhinoplasty. She's a primary case, but when we take a look on this face, you can already notice some asymmetry. So you can see that her right eye is lower than the left eye, and on the same way, this length here of the face is shorter than this side. And you also can notice that this piriform aperture here seems to be lower than this side. We're going to double check that during the surgery on the base view so we can make some corrections. But you notice also that it's not only coincidence, but this side of the face is shorter, so her nose tends to make deviation to the right, because if we think on the tip as a triangle, this side here has lower support than the other side. And it's also combined to some septum deviations that we're going to check on the CT scan. So this is her front view, going more on details on her complaints about her nose. She complains mainly about the deviation and also the lack of definition on the tip. So it's very common for us in Brazil and also in Latin America to operate these kind of patients. They have medium thick skin, sometimes thick skin, and they don't have definition. And once we open this nose, we have a very weak cartilage normally. And we're going to check that during the surgery, but we chose to operate this patient through an open approach, especially because this is a demonstration of the techniques and I want you to see everything. So our surgical plan, I'm going to talk in a few minutes, but you can also see on her profile that she has an S-shaped hump here. We're going to confirm that with the CT scan, but her nose has a hump here. Her radix seems to be a little low, and her supratip also is not so high. So this kind of nose is very common in our region, and we have to understand what's going on here, because if we understand, we can choose the correct techniques. Example here, if you take the measurements of the radix and then the transition between the bone and the cartilage, and then the supratip, and then the tip, you're going to have some measurements, and these measurements can guide us during the surgery. We're going to talk a lot about this during our course, about the measurements, how to use it, and how to do the simulation based on this, because this can change your surgical plan. Well, our surgical plan today is to try to check during the surgery which kind of hump she has here, and after that treat the hump, and also analyze if we need or not a radix augmentation here. And also the tiplasty is very important, because remember, one of her major complaints is the lack of definition on her tip. So based on this, we used Photoshop. On these other incidents, we can see the shape of the bones, but mainly the septum deviation and the location of the septum deviation. I use as a parameter the intermediate turbinate to know how deep I am here, and every time I'm dissecting the nose, when I see that I'm on the level of the intermediate turbinate, I know that I cannot go up on the dissection, because here we have the olfactory nerves, and we can also notice how big is her inferior turbinate, and probably in the surgery I'm going to out fracture at least, and sometimes we remove part of the mucosa and the bone if necessary. And here on this CT scan, sometimes people don't give too much importance to this, but on preservation is important, because here you can see the shape of the perpendicular plate, and here you can plan what you're going to do. It's a little S shape, you can see here it's a little bit more S shape. I have to rasp this, convert into a V shape, but mainly if I know that there is a perpendicular plate under, I know that if I will use dorsal preservation techniques, I have to treat first the perpendicular plate in order to drop the bony part down without making any other fracture on the perpendicular plate, and this is part of the safety of the preservation rhinoplasty. So this is important to study and have an idea, and also to plan yourself for the surgery that. Okay, colleagues and friends, first of all, thank you so much for being here with us. We separated here a very special case for you, and there is a reason why we chose this patient, because I think it's very similar to most of the cases that we have in our routine in Latin America and Brazil. And I'm very happy that you're here and you're interested in our lecture today, and also in our courses at Perface Academy. So thank you so much, everybody, and let's start the surgery, and I hope you enjoy, and I hope I can help you guys to improve some techniques and some more arsenal to your practice in rhinoplasty. So let's go here. If you analyze this case on profile, she has a low radix, she has an S-shaped hump, a little deep supratip, and also weak cartilage here, so no support. When I palpate here her septum, I can feel that her septum is not so strong. So this patient needs support, and her major complaint is the lack of definition on her tip. So I need to do something here to give her more definition. So it's a little challenging case in terms of preserving this dorsum, but I'm going to use this case. I'm going to open this nose to show you inside how can I do if I want to structure, open the roof and structure, if I want to use spare roof A or spare roof B, or other types of dorsal preservation that I think that could be possible on this case. So now let's take a look on the helicopter view. On the helicopter view, you can see also her deep radix, a very S-shaped hump here, and very wide nose. It starts very thin and becomes very wide. This is a very common complaint in our patients, and no support also on her tip. And now I'm going to show you the incision of the open approach. Normally, I do nowadays my primary cases close approach. The reason why I'm going to open this nose first is because I want to show you everything that I'm going to do inside, and second because as I said, I could do this close approach, but of course it's easier when you do open approach. This is not an easy tip, and also I'll have to reshape here. You can use rasps or you can use piezo as well. I'm going to show you both, right? And talking about the incision, that's one of the basic questions, but also very important. When you look on the base view, you tend to find the thinner part of the columella. For me, it would be around here, the thinner part of the columella. Okay, and it's very important also to break this incision. And when I want to break this, I want to create a little triangle. But you can do an inverted triangle, you can do a stair step. I don't like so much stair step, but you can do whatever you want as long as you break these. Don't do a straight incision, okay? So some nuances here. If you want to project a lot the tip, sometimes I do this incision a little lower because I'm gonna gain some skin here to the top, okay? So on this case, I think the projection I'm going to keep more or less the same, but I'll work a lot on the definition. Okay, now after we do the incision here on the columella, we do the lateral incision, which is infracartilaginous incision. Sometimes you call it marginal incision, but sometimes marginal refers to the margin of the nostril, but could be marginal incision if we're talking about the margin of the cartilage. So we can see here, when I push my finger here, I can see the limit of the cartilage, and that's the point where I'm going to do the incision. And another reference that we can have is the area where you have hair and where you don't have hair. So if I would mark here to show you, normally I don't mark, but this is the margin, so now you can see a little bit better the margin of the cartilage. One of the most tricky parts for beginners is when you turn here. So you can see that my double hook here, I put in a position that I don't move the position of my hook. I just move my finger. I put lateral here. I can see that inside. I can put on the soft triangle and I expose the area of the soft triangle. And I can push here the columella and I can connect my incision there. So this is the way I like to do the incision, and this is the way I'm going to show you. So I like to start my incision here, and also the dissection. I like to do the dissection laterally first. I think it's easier to find the plane that you want to go. So now I turn here to the soft triangle. You cannot do the incision too close to the soft triangle because you can have retractions after the surgery. And then you connect to the incision of the columella. So as I said, I like to position my scissor this way, perpendicular to the incision, because with one of the legs of my scissor, I can feel the cartilage. I can feel the resistance, and I can open the space where I go on the top of the cartilage. Once I do that, I take a single hook, and the single hook goes here close to the area of the turning point of the cartilage. And then here there's a lot of soft tissue, and this is the part that you find the upper part of the cartilage. You dissect, and then you choose if you want to go supraperchondral, subperchondral, subariolar. So this is the timing of the surgery where you decide that. So I like to go close to the perchondral, but because I have a lot of weak cartilage patients, most of the times I try to leave the perchondral to give more strength to my cartilage. So once I find the plan that I want, I come with the dissector, and I start to expose my cartilage. So far, the same maneuver that I'm doing here, I can do in a close approach when I'm doing without incision on the columella. We're opening here the columella, and we can dissect the arteries here. Sometimes it's larger, sometimes very thin. We like to cauterize. And then we cut it. There's 6. And then we connect these areas using the little traction here of the single hook, because with this traction we can connect the dissection of the lateral crura and the middle crura, and being very careful here exactly on the transition. So I do one side. See how it's important to use the traction, the counter traction, because this way you can expose much better. So at this point, we have a superficial ligament here that connects here and also connects to the sum, to the orbicularis oris muscle, and it's responsible for the tip going down every time the patient makes a movement here of kissing and not so much smiling. But here, when you dissect a little bit more, you have the deep part of Pitangui. Deep part of the Pitangui, some people believe that it's very important for the stability of the tip. I believe ligaments are always important, but when you're using septal extension graft, it is not so important for the stability of the tip, but it's important to close that space and also to reconnect these structures here on the tip when you're closing. So what I like to do most of the times when I'm using septal extension graft is cutting here, and at the end of the surgery I can reconnect to close the super tip and avoid liquids here in fibrosis on the super tip area. So here we have the dissection of the tip. You see how big is the cartilage and how weak it is also. And I like to show you here that I can dissect all the lateral wall, the cartilage here, the bony part here, and I can dissect all the lateral wall just like I did here, preserving the central part not dissected. You see my scissor doesn't go to the other side. I'm going to open all this roof to show you, but I'm just showing you before dissecting that when I'm doing dorsal preservation in some techniques, I preserve the central part of the dorsum not dissected, which is also a plus on the post-op, because if you don't dissect, you don't have fibrosis, and you won't have any kind of complications or irregularities. But to choose this kind of techniques, you have to have a good dorsum, a straighter dorsum, V-shape, which is not this case. So I'm going to open here now just to show you, but I already dissected both sides on the lateral wall. So you see now I open here the cartilaginous roof. It's supraperichondral dissection so far. Now you can see better the lateral wall dissected, the central part not dissected. And now I can go for the tip here. I come from back to the front, dissecting this part here, which is the sling. All the ligaments here together, interdomal, transdomal, and also connected to what should be the Pitangui, deep part of Pitangui ligament. When you dissect back to the front, we have an interesting thing here, which can be useful in patients who have a very long caudal septum, but in short caudal septum, not so useful like that, because this sling is a very strong structure that it's a theory described by Dr. José Carlos Neves from Portugal. If I dissect here in front of the septum, all this structure is really, really strong. And in some cases, if you have a long caudal septum, you can lift this and suture on the caudal septum. But I don't have this long caudal septum. So in these patients, I have to create the septal extension graft to create this stability here. But you see that it's very strong. My assistant here, Anna, will pull the cartilage down without, she's gonna pull the cartilage down when I'm not grabbing the sling. And now I'm going to hold it. You can see how strong it is. You see, even when I open this, as I'm going to do now, when I'm doing the septal extension graft, I tend to put one suture or two sutures trying to connect this strong tissue to the septal extension graft. It's a way to reconstruct the anatomy. Well, one of the important steps here on the tip, especially when we have weak cartilage patients, is the first 1 centimeter of the septum. I like to dissect supraperichondral. At this point, you see it's a bloodless surgery, but the caudal septum tends to bleed a little bit more when you go supraperichondral. But the reason is the cartilage is already weak. If I preserve the perichondrium, it's going to stay stronger. And the second reason is when I put my septal extension graft here, the perichondrium helps on adherence of the septal extension graft. If I don't put it and I dissect subperichondrium, both the graft and both the caudal septum, sometimes we have a very unstable graft, and in long term sometimes it's moving. In some revisions, when we do that, we can notice that the graft is moving, and it seems that was not even sutured on the caudal septum. So next step here, I change my plan from the supraperichondral to subperichondral, and I dissect the rest of my septum to harvest the graft that I need for this tip structure. Here, just to show that I dissected all the lateral wall, but you see I cannot go on the upper part. I can go lateral but not on the upper part because I preserved all this dorsal line. On this patient, I'm going to dissect, open, and reshape this bony cap. But I'm just showing to you that if I was planning any kind of dorsal preservation, that is a V shape, that I don't need to reshape the bony cap, I can preserve this central part not dissected. So it could be not dissected, preserving even more the structure. So you see on the other side the same thing, lateral wall dissected, but the center part not dissected. Okay, two important tips here. One, this patient has a long lip, and I wish I could have some volume here to open her angle here. So one of the first maneuvers that we do is we dissect very close to the caudal septum, but we preserve this area not dissected. Some years ago I used to dissect it very close to the skin, but I want to preserve all this soft tissue, because once I put my graft here, the soft tissue will go to the front and help me to create some volume here that she needs. The other important tip here is, after I do this supraperichondral dissection, I have to do the transition for the subperichondral. The most common way to do that is using a blade. So you scratch a little bit, and then you go with your aspirator or dissector and turn your surgical plane to supraperichondral. Supraperichondral plane is bloodless, so you can see the difference now. It was bleeding a little bit, now it's not bleeding, and the rest of the dissection is very easy. Okay, now I'm going to remove a little piece of graft from the ear, because ear cartilage, I think it's good when you're using a contour graft, or on this case I'm using only to give volume to the nose. I need a radix graft, and I already noticed that the septum is very weak and short. So what I remove from the septum I'm going to use for the tip graft, and I'm going to remove the cartilage from the ear, to dice it, mix with PRF, and then put it on the radix. The way I like to do is I preserve this part here, I should not touch. So the limit I put here, and the anti-helix also I cannot touch, so I mark here. So all this other part here I can remove safely and without major complications. So as long as I preserve that, because I'm removing the cartilage for my graft, I can do a hydrodissection. It's a little different when you're removing the graft to use as a composite graft. If you're using as a composite graft, you should not do the hydrodissection, because you want to preserve the skin attached to the cartilage. In this case, it's not, so I prefer to do the hydrodissection on this side, and we do the incision on the other side, and it's very easy to remove. Now I do a little infiltration here. I do an incision. I dissect with the scissor. Now we put the hook here, the other hook here. I can cauterize. Okay, the way I think it's very useful, because I mark it inside already, I put my needles as a reference, and when I use these needles I already know exactly where I can cut or where I cannot cut, so I don't need to make tattoos. Here I just find my needles and I just connect and then I will remove exactly the cartilage that I marked in the front part of the ear. So when I put my needles on the front, it's very easy because here I can already know exactly the shape, and then I start cutting exactly there, and I'm confident that in the front part I'm preserving the structures that I plan to preserve since the beginning. So here is the area that I removed the graft. In this graft, as I said, I'm not considering to use as a structural graft on the nose. I'm using to dice it, mix with the PRF, and then use as a filler on the radix. So the PRF, we use the blood of the patient and then we do a centrifugation of the blood for 12 minutes in 2,700 rotations. So my nurse now is removing the membrane, and you can see it's very beautiful, and it's really a membrane here. It's hydrated. Sometimes we can dehydrate it also, and it turns into a real membrane, just like I'm going to show here. And this piece of graft, we're going to dice it and mix with the membrane and also with the IPRF. IPRF is a liquid part. We do the same thing, we remove the blood, but we do the centrifugation for 3 minutes, and it turns into a liquid that works as a glue. So here I'm going to show the membrane, dehydrated, and on the side I'm going to put the membrane, hydrated. So you have these two forms. Normally we dice it here and we mix, but the membrane works as a, you can cover irregularities, you can fix some grafts also with the membrane. It helps on the healing process. It's amazing, very easy, very cheap, and we use it very frequently in our surgeries. So as I said, the radix is very low, and this is very common in our noses. We have to feel the radix. If you dissect all the dorsal, you have difficulties to put a graft here and make the graft stay where you want it. One tip is, if you dissect everything and you do full open, I like to use a membrane of PRF with diced cartilage because it sticks here and it stays more stable on that position. If you don't need to do a full open dissection, you can do what I'm doing here. So one of the tricks here is, here's the cartilage. You see here is soft, this cartilage. Here is already bone. Here is cartilage, here is bone. Also here is cartilage, here is bone. So the dorsal part on the bone here is not dissected. So what I create here is a tunnel. So it's a superosteal dissection, creating a pocket for my diced cartilage. And then I use an injector, cartilage injector, to feel the radix on a precise pocket in a precise position here, as I'm going to show. And I only expose and dissect the bony cap that I have to sculpt and I'm going to show you how I sculpt both with the rasp if you don't have a piezo and with piezo if you have it. This is the marking that I did, the limit for my pocket. My reference of this marking point is the patient with the eyes open on the limit of the upper eyelid. So here is my pocket, not dissected to the sides. And now I'm going to dissect only here the bony cap, and I will use the rasp and also piezo to show you how I reshape this bony cap. So first I'm going to use rasp. If you don't have piezo, you can use rasp. Remember, if you preserved the pocket on the upper part, you cannot go with your rasp all the way up. You have to go only with the tip of your rasp here, and also with piezo. If for some reason you dissect your pocket, then you have to switch the technique of only filling the pocket with diced cartridge. You have to switch it for another technique to keep the diced cartridge on the radix. My second option is to create the membrane of PRF and diced cartridge. So I use only the tip of my rasp and I start sculpting the bony part, but on the same time preserving the connection of the structures. I can remove it with an osteotome, but when I remove the osteotome, I already open the roof and remove also the periosteum, the perichondrium of the cartilage. And this is good when you're doing open approach structure rhinoplasty. When you're trying to preserve the cartilage dorsum, if you do that, you violate your central key area. I want to preserve my central key area and maybe do the lateral key area release if I'm planning to do a spare roof A. I'm going to stop a little bit to explain you the differences between doing the structure rhinoplasty open approach, spare roof A, Ishida, and spare roof B. Okay, the first option here, maybe for most of you, which is already used to structure rhinoplasty, is this is the dorsum. In structure rhinoplasty, what would I do? I would come inside here, open the mid-third of the cartilage, disconnect the dorsal cartilage from the upper lateral cartilage, and then I would remove this bony cap in a unique component, cartilage and bony part. When I remove that, it's very easy. My dorsum will become straight, but I'll have to reconstruct. In order to reconstruct this, I need to do maybe a spreader flap or a spreader graft to reconstruct the dorsum. But remember that the normal anatomy here is a unique structure. You see that the structure is connected. The cartilage comes from the septum, and like an umbrella, it opens here on the upper lateral cartilage. And the dorsal lines here, for me, is beautiful. Here is a little wide, but here is beautiful. So I don't want to change this. I want to preserve this. If I don't do structural rhinoplasty, the second option here that I have would be preserving the dorsal part, both bony part and cartilaginous part. To preserve both, I have to have a beautiful shape of bony part and cartilaginous part. This patient, as you saw, the bony part is a little S shape. I don't want this. I will have a hump that was not treated. So my second option here is a spare roof A. This technique was described by Dr. Miguel Ferreira, and on this technique we rasp here the bony part with manual rasp or with a drill or with piezo. The difference of rasping is that when I rasp, I remove gradually the bony part, but I preserve the soft tissue here. If I preserve the soft tissue, I'm preserving the central key area, which is important when I'm doing a dorsal preservation, cartilaginous dorsal preservation, and combining with the lateral key area release. If I release all the lateral key area, the central key area should be preserved. Talking about another technique, which is Ishida, is different. It's very different because on Ishida, you remove the bony cap, the classic Ishida, you remove the bony cap, but you disconnect the central key area. And then you start releasing the lateral key area gradually, but you never release everything. You have to keep it attached here on the piriform and also on the lower part of this lateral key area to avoid dropping down all the dorsum, because you don't have the central key area anymore. So that's the big difference between Ishida and spare roof A. Okay, so in the new Ishida technique by Luis Carlos Ishida, you preserve a little triangle here, but you still disconnect the central part on the upper part of the triangle, and then you rasp the bony part reminiscent here, and also you release gradually the lateral key area, preserving the lower part. So my preference here on this case will be spare roof A. Spare roof A means I will sculpt this bony cap, turn this in a straighter dorsum, fill the radix with some diced cartilage, and if necessary, I'll drop only the cartilaginous part down using a high strip or a middle strip or a low strip. Why this is spare roof? Because I'm preserving the connection here on the central part, and if necessary, I'm going to do the lateral key area release until the lower part, and then do the lateral fracture to make this nose straighter. So what I wanted to show you, that you can do this with the rasp and you don't need piezo, but if you have piezo, you can also use it, and I'm going to use to show you. This is a rasp, a strong rasp of piezo. I'm using to sculpt this bony part and turn it to a straighter dorsum. And piezo is even better to preserve the connection here on the central part, because again, if I'm planning to do a spare roof A, it's important to preserve the central part in between the dorsal aesthetic lines that I desire. Okay, so I'm going to use here and show you. So now you can see that I removed the bony cap. And then when I removed the bony cap, I ended up only with the cartilage dorsum. In the cartilage dorsum, I have two options: or I open, remove it, everything like an open approach, cutting the dorsum, but then I have an open roof and I have to reconstruct. And the other option that I'm going to choose is to preserve this cartilaginous dorsum. But to preserve it, instead of opening the valve, I'm going to drop it down, cutting the central pillar, which is the septum. To do that, I like to use a scissor. I cut under the dorsum to do a high strip, and then I remove a little strip under the dorsum, combined with the lateral key area release, and this will come down without opening this. So that's my surgical plan in the spare roof A. I have many other options here. That's not the only option. I'm only doing the spare roof A here for one reason. Number one, because it's an S shape. Number two, because I want to show the easiest option that you have on the transition from structural rhinoplasty to dorsal preservation. Because when we do spare roof A, imagine with me that you do a cut under the dorsal. If for some reason you regret and you want to convert it to an open approach structural rhinoplasty, you only open the mid-vault and you are back to your comfort zone again. So that's why I think it's the best option to start a dorsal preservation and come here that I'm going to show inside how would I do that. So here is the dorsum. As I said, the first step here would be a high strip. Here's the anterior septal angle, here is the W point, and here is the vasa segment. Imagine that in a structural rhinoplasty, I have to cut here, cut on the other side, drop down, and reconstruct. On the dorsal preservation that I'm going to do here today, a high strip, because I think it's the easiest way for you to start, I cut under the dorsum. Until I reach the perpendicular plate. Once I cut under the dorsum, and if you feel that you're not safe and you feel that you're not confident to proceed with the procedure, you come here, open the mid-third, and you're back to the structural rhinoplasty again. So this is the easiest way to start your dorsal preservation surgery. Now I did the first cut, I'm going to do the second cut, because the second cut I can remove a little strip and then I create a gap for this to come down. To come down better and release the memory here in the blocking point, you see that the central part is preserved. It's not disconnected from the bone, but I will disconnect the lateral key area, and then you will see that this dorsal will become straight. So I come with a straight scissor and I do the second cut. And after I do the second cut, normally I have a little strip that I removed under the dorsum. This strip is, in theory, what I want to remove in height, and then my dorsum will come down because I created on purpose a gap under the dorsum until I reach the perpendicular plate. Here's the lateral bony wall, and here's the connection, the lateral key area, the connection between the cartilage and the bone. So because my central key area is preserved, I'm releasing everything, the lateral key area, until the piriform ligament. I do the same thing on the other side. And this in dorsal preservation can be considered, it's considered a blocking point on the descent of the dorsal cartilage, because it blocks the cartilage from going down. So now that I removed the strip under the cartilage dorsum and did the lateral key area release, you can see that I have almost a total straight dorsum. Okay? So these I can adjust. If I want to remove a little bit more, I go inside, remove. If the cartilage is curved like that and still have a little strip here, I can do little cuts as I'm going to show with the video. And if you do that, you can break the membrane here. But you see, now it's pretty good for me. Dorsum is okay. I was planning to feel a little bit here the radix. I'm still planning to do that, to elongate this nose. But now what I have to do is remove my septum graft, fix this dorsum here in the position, and start constructing my tip and give better definition here. So you can see now that the caudal septum is here, the cartilage is here, and if we go very high, you can see the disconnection of the dorsum. And here is the dorsum disconnected, the little strip there, all the way back, and I have all the cartilage here to remove my graft. So one of the fears of people who are transitioning to dorsal preservation is to have that your dorsum can come down and create a complication. But you see that on this spare roof A that I recommend, that is one of the first techniques that you have to apply, you have possibilities to convert. I have this septum here. The part that cuts here on the 15 blade has around 1 centimeter. So I measure that 1 centimeter here. If the patient has a weak cartilage, it's good to leave as much as you can. But I tend to leave a strong frame. I come up here. When I transition from the vertical cut to the horizontal cut, I try to do a round cut. I try not to do a 90-degree cut, because if I do a 90-degree cut, I break, I have a more fragile frame. So now I come with a straight scissor and I touch until I touch the perpendicular plate back, and then I have my graft to structure whatever I need on this surgery. So after doing the cuts and releasing from the perpendicular plate, I remove my graft, which is a good graft. I think I can do every structure things on this nose. Remember that I don't have to do spreader grafts because I don't need to reconstruct, so it's very good because I save cartilage for what really matters, which is the tip. I have to use part of this cartilage to do the extension graft and part of this cartilage to do maybe a tip graft or articulated ring graft. So I'm going forward on this surgery. This is the tail of this cartilaginous septum, which is very good for some grafts. And this is the part that I'm going to use mainly for the tip structure. So I want to do a paramedian fracture because I want to mobilize this bone that is very wide medially. So I can use an osteotome, straight or curved. You follow the dorsostatic line and you go straight up, creating here a cut more or less like that, okay? And then you come with the lateral fracture and you break in green stick and this bone will come inside. The other option, if you have piezo, which is very precise, you come here and you do the same cut but using piezo to control exactly what you're cutting. And remember, the width here is the width that you desire for your new dorsum. The lateral fracture, I like to do an incision with my electrocautery. I do already on both sides, and then I dissect the tunnel. And maybe you're asking why I'm doing that here, if I can do inside and use piezo. The reason is, first, I want to show that you can do it manually also, because many people don't have piezo. Many people watching us here don't have piezo. So you create your tunnel. If you do the incision with electrocautery, it bleeds less. You have to try to keep superosteum here. If you do that, you avoid some ecchymosis and bleeding, and you have less bruising after the surgery. And the other reason is to use piezo very down here. I have to dissect a little bit more than I dissected inside. So I didn't dissect all the dorsum. So it's up to you, but here I'm going to show how do we do with a manual osteotome and show you that it's totally possible to perform this surgery without so much specific instrument. So I'm going to draw here what I have to do. Okay, this is the bony cap that I removed. So I have a bony part open roof. So the open roof goes until here. So what I did here is a cut to the upper part like a paramedian fracture. And now I'm going to do a lateral fracture here, and this part will connect as a green stick fracture, and all this bone will go inside. So now it's a very important step on the surgery. We have to decide where we're going to put the tip. So we already did dorsal preservation. Here is period A. We still have to feel a little bit our radix and maybe the super tip, because remember right in the beginning she had a very S-shaped hump, deep super tip, deep radix. So what I do is I put my forceps inside here and I try to check what is the desired position for the tip. I use a lot the comparison with my simulation during the consultation, because this is my guide, because this is what the patient approved with me during the consultation. So imagining that the tip of my forceps is the plateau of the tip. What is the plateau of the tip? Exactly the junction between the domes. So here is the dome, cephalic dome position, and the two tip defining points. So when I put my forceps here, I'm trying to position exactly this plateau that is going to be more or less like that. Okay, so coming back here for what we're doing, this is a thick skin patient. I'm going to position my graft here, and maybe I still have to do a tip graft. So if I consider this is my tip position, I uncover the skin and I put my forceps on the face of the patient, so I move almost nothing, and I put a sterile paper from the suture exactly there. So my assistant here marks the tip of the forceps, and remember this is the plateau of my new tip. If this is the plateau, I have to have in the front a little infratip lobule. I like to position it around 4 millimeters. We're going to measure this, and the caudal septum is very short, so it will come down all the way until I touch here the caudal septum. Even doing that, remember I saved here in front a very big soft tissue to create volume and also improve my angulation. I use here the blood to print my paper, but also I mark my paper with my pen, and I draw here this super tip position. Should have, imagine that this is a continuation of the dorsum, should have here around 30 degrees more or less, but depends on the thickness of the skin. And also I like to draw this line straight here with the caudal septum, because when I do that I create an axis, because when I come back I want to position my new graft position on the same axis that I'm planning right now. So the stereo paper I used to have a reference for my new graft. As you see, I don't have a big graft, so I'm going to position it one side, and I'm going to use this or this graft to stabilize on the other side. So it's like a double extension graft, but basically one side only I do the shape that I want. So I'm going back to the caudal septum now. I'm going to suture it there, stabilize on the other side, and I still have some grafts here if I need a tip graft or articulator and graft. And remember, we removed cartilage graft from the ear because I already expected that I didn't have so much material to do the dorsal graft as well. So I draw the grafts, and you see the marking that I did before was exactly to use as a reference here when I come back. So now I put it on the position, I put on the rotation that I desired before, and now I can put one suture first and check the position of the graft, and after that I can proceed with all the other sutures. So I always put one single suture before just to check the correct position. And then I put the other sutures. So we position here the septal extension graft. We did a stabilization here on the right side, and now we're going to start structuring the tip. And the first step here is to find the new dome position. So we do a little tensioning of the lateral crura until it reaches the height of my septal extension graft. So you see here that if I do a little tension, it's there, my new dome position. If I find this new dome position, I transfer to the other side to make a more symmetric as possible position, and then we suture, we mark with the caliper around 5 to 4 millimeters. So from this point, I start drawing the puzzle. The puzzle means that we are going to connect all structures. So if I imagine this is the dome position, and this will touch here on the tip of my septal extension graft, and the cartilage should be flat like this. This part should connect here on this part of the extension graft. So I don't remove longitudinally, I remove what is sufficient to connect here. And on the same way, this part is overlapping the other part, the upper lateral cartilage. So when I think on the position here, I imagine that there is an excess of both cartilage, especially on the upper lateral cartilage, because remember that when I preserve the dorsum, I stretch to the front this cartilage. So probably I have to remove a little bit from the lower cartilage, but a little bit also from the upper lateral cartilage in order to fit one cartilage to the other and create the puzzle tip plasty. You see that I'm removing only what is in excess from the lower lateral and upper lateral cartilage. So now I have a better connection between structures here, and if I need, I can remove more. So in the beginning, remember how deformed was the cartilage. In this side, we already did the 2 cuts of the puzzle tip plasty. We put Milosevic suture, Gruber suture, and you see how we can change the shape of the cartilage only with that. This side we didn't do anything except the cuts here. So I'm going to put now the Milosevic suture first and then Gruber suture, and you see the changes that we can make on the cartilage only using sutures. So I'm reshaping the cartilage. I'm not removing in excess. I'm giving shape, giving position, improving the lights and shadows of the cartilage instead of resecting and removing. Next suture here is to make the new dome. So I'm putting the first suture, connecting the domes here, but not to equalize them, just to make it closer. So next suture is a suture to equalize the dome position. You can have several ways to do that. One of the ways that I do different ways, but One of the ways is a figure of 8 suture. So what is a special thing about the figure of 8 suture is that it equalizes on the same height the position of the dome. And what I want here is exactly close the proximal part and create a divergence here of the two tip defining points. And when I talk about a little plateau of the tip, is this part here, creating a triangle here with the two tip defining points that will give the definition to my dome. This is an important suture, an important step of the surgery, because this is the reconstruction of the scroll. The scroll reconstruction is important because I'm reconnecting the upper lateral with the lower lateral cartilage, and exactly below this structure there is the internal nasal valve. So what I want to create here is a little tensioning in between both cartilages in order not to have a collapse of internal nasal valve. Imagine that if I have a big overlap in here, it will compress exactly inside here the internal nasal valve. So I remove and create the puzzle, the connection, and I like to put slightly under the lower lateral cartilage, slightly under the upper lateral cartilage to create the shadow that I need, and on the same time recreate the connection between both cartilages and treat functionally the internal nasal valve and aesthetically creating the shadows. So I have this cartilage injector. My scrub technician, Edna, she works with me more than 10 years and she does a very good job dicing the cartilage very well, and she mixes with the PRF. So with this injector I can go straight up to the radix and I can feel there, and also I can put a little bit on the transition between the bone and cartilage because it's I spare with A, and exactly in that position we always have a little chance to have some kind of irregularity. So remember, we did a cartilage dorsal preservation. We didn't preserve the bony part because it's a spare roof A. So you see it's like a cartilage gel or cartilage paste, and we can put there on this position. We can also use membranes of PRF if we want, and we can fill some areas that we consider that could have some irregularity. So you can see it's very good for some refinements, but I advise you that it's important to use diced cartilage with PRF, not diced cartilage alone, because you can have some problems related to the scar formation and also contraction, and you lose control of the diced cartilage if you don't use PRF. So the method of PRF that we use is from Dr. Manuel. He has an article published talking about that, and it's very useful that we use in our routine. Okay, now we're reaching the end of the surgery. I'm pretty happy here with the result on the dorsum. Remember, here there's a little radix graft, but the dorsal cartilage was preserved. We did a spare roof A technique. Now we have here the plateau with the tip defining points, super tip break, super tip, and all the dorsum here totally different, a transformation comparing with the pre-op. Here on the base view, you see that I could lift the lip, and now I have a much better angulation. Before was a close angle, now there is a 100, 105 degrees, and I have all the breaking points that I need. In the closure here, I put first one subdermic suture, and then I suture here, here, and here. So these three sutures first. And then exactly the margin lateral here should be perfect to avoid any kind of step. And then we close inside. And last step, we do a circling suture here, combining foot plate suture with a tongue and groove suture, which is important to keep the lip on the position that I left. All right, colleagues and friends, rhinoplasty lovers, we finished here this surgery. First of all, thank you all for being here today. And you could see the main steps of this surgery since the beginning. And the reason why we chose this case is that I think it's very common to have this kind of situations in your own practice. And what we want to show you that you can use the structure approach, you can use dorsal preservation approach. And here we use it, in my opinion, one technique that is the first one that you should use when you are transitioning from structure to preservation, which is Spare Roof A from Professor Miguel from Portugal. And we did a dorsal preservation here. We kept the radix here a little higher because we grafted here diced cartilage. We preserved the cartilage dorsum. So it's a cartilage dorsal preservation because we removed the bony cap. We couldn't preserve the bony part because she had an S-shaped dorsum. So we corrected the dorsum, the bony dorsum, but then we drop it down the cartilaginous dorsum through a high strip, preserving the central key area, releasing the lateral key area, combining lateral fractures with paramedian fractures, and then at the end we structure here with a strong septal extension graft from the septum. And I think she's now with a good rotation, good projection, good stability, and also a lip lift that we did through the incision. At the end of the surgery, we did some refinements with pre-diced cartilage and PRF, and I think we could achieve a very pretty result and a good transformation for her. Now she has a good angle here, was very bad before. Infratip break here, a good infratip lobule, tip definition, the plateau here is okay. She has a break here, the dorsum is straight, everything preserved, very little chances for her to have irregularities here in the future. So hope you enjoyed this surgery. Thank you so much for watching us today, and any doubts, please contact me or my team from Perface Academy.
All right, my friends, thanks again for being here. It was a great pleasure to be with you. Well, as you saw here in our online program, you can watch from the comfort of your home. I think most of you were seated in a very comfortable position watching the surgery, and we as surgeons, we love to watch surgeries, right? So I'm going to put here the other part of the presentation. Just a second here. Gabriel, could you please share the screen? Yes. Okay. So now you might be wondering how to put these techniques into practice and start seeing your results. Okay, so that's the next step. because um, transition and changing your techniques is not easy. You leave your comfort zone. So we can help you to transform your surgical practice and become a reference in rhinoplasty. I know most of you already are references in your country, but the rhino from A to Z, we go from the nose diagnosis. We teach you how to do the infiltration. You saw that in the surgery, we finished the surgery almost with no bleeding, no bruising. And we have a lot of thick skin patients in Latin America and Brazil. So we talk a lot about the thick skin protocol, how to augment the dorsal. And you saw a little bit here, but dorsal augmentation is very important and step by step of the structure. So to increase the precision and quality of your rhinoplasty procedure. So that's the point. You have to incorporate new techniques in your practice, even though you are already having good results. Things are always evolving in all fields of plastic surgery, so we cannot stay stuck. We have to evolve every day 1%. Increase your confidence in safety in performing nasal surgery. All of you know that when we are starting rhinoplasty, we suffer, right? If tomorrow I have a rhinoplasty, I suffer because it's a painful surgery. It's not an easy surgery. So it's not only you, okay? Everybody already passed it through this, and a lot of surgeons, I guarantee that they don't sleep before the surgery. Improve your ability to serve more demanding patients with Instagram, selfies, um, video conferences. Everybody's looking to themselves, so they are very demanding patients and very high expectation patients nowadays, and we have to improve also and develop skills in digital marketing, specifically for plastic surgeons, because this is very important for our career as well. So Rhino from A to Z is for you if that makes sense. Okay, we cover from the basic steps of rhinoplasty, nose evaluation, decision making in rhinoplasty, how to perform a clean surgery, do the infiltration. We go from the routine, what we do in our office, on the simulation, photographs, how can you build your own studio, and how to perform the osteotomies, piezo surgery, structural grafts, because a lot of you are still doing only structural rhinoplasty, and I really think it's important. And the evolution of rhinoplasty, in my opinion, which is incorporating preservation rhinoplasty. It's not changing everything, okay? But once you start incorporating concepts of preservation in your practice, you definitely will evolve in your practice. How to treat dorsal preservation, dorsal augmentation, deviated noses, puzzle tiplasty. I showed you today a little bit, but there are a lot of other tips and tricks that you can incorporate to reach that very defined tip. And well, how to use fillers and what really matters in CT scan, and how to treat also complications, which is very scary for those who operate rhinoplasty. So talking a lot of a little bit about the price. The regular price of our course, the Rhino from A to Z, is 1,553 US dollars. But uh, today specifically, we have 50% discount for all registrations until midnight today. Okay, so we have this special condition for those who do the registration until midnight in Brazilian time. So 869 US dollars. So the next step, my team will send the registration link on the chat so you can get your special discount and talk to any one of our team to um, and ask them anything you want, okay? And you can discuss with them. And just recapping what you receive, um, if you get the Rhino from A to Z, inside the platform you have master classes, you have doubt sessions, you have edited surgical videos similar to this one that you just saw. And today we have this special discount, okay? There is a 15-day trial. If you don't like it, you receive everything back, and registrations will finish Friday, this Friday at midnight. Okay. So, any questions? I'm here to answer, and all my team also are here to answer you. And well, as I said just before, you uh, just before you ask more questions, we have nowadays the opportunity to study and to evolve in our profession anywhere, anytime, any place from the comfort of our home. And I think that's remarkable, okay? Because in the past, we had to travel many hours, spend a lot of money to incorporate new techniques. And nowadays, this makes possible uh, our update in our professions, in our knowledge, in the comfort of our home. Okay, so um, that's a huge pleasure for me to be here and to be with you and to have such a lot of students from all over the world, everybody together that we call the community state of the art rhinoplasty lovers. So thanks again, everybody, for being here. Okay, let me see here. Thank you, everybody. Gracias. All people from Pakistan. Thank you. Thank you. Nicaragua. Gracias. Muchas gracias. Thank you, my brother Marcelo. Thank you very much. Okay, guys. So, um, okay, one question here. Which instrument you and how? Okay, from Yemen. Thank you. Thank you, my friend. Very nice. Um, Second cutting of the dorsum, please. Such instrument. Okay, nothing special, right? We use iris scissor. You can use iris scissor or medicine ball scissor. Okay, no special instrument to cut the cartilaginous part of the dorsum. Okay, just remember that in some types of dorsal preservation, you have to remove also a little bit of the perpendicular plate. And for that, I recommend you to have a special instrument. In your country, maybe you have higher dorsums, and then you can use like a runger, and you can remove a little bit of perpendicular plate and drop it down. In some cases that the dorsum is already low, it's better not to remove a little bit of the perpendicular plate, but cut it. You can cut with piezo, or you can cut with special scissors for perpendicular plates, okay? Not any type of scissor. Okay, gracias, muchas gracias. Okay, Anderson, yes, you can talk to my team, okay? They have all the information, okay, for maxillofacial surgeons as well. Just click on the link and talk to Luciana, please, okay? Saludos Argentina, gracias, muchas gracias, hermanos de Latinoamérica. Oh, from Ireland. Thank you, Luigi. Thank you. Macedonia. Wow. Later, I'll make a review from which countries were you all from. It's amazing. I love this. Gracias, Gustavo. Okay, Italy, grazie. Thank you, my friend. Gracias, gracias. Lifting facial. Sim, sim. Yes, Vianney, gracias. Sí, estamos planeando un curso de lifting facial. Venezuela, saludos, Paraguay. Gracias, Diego. Ok, another question. Felipe, ¿usted cree que es indispensable el piezotomo? Felipe, no es obligatorio el piezotomo. Ok, piezotomo, claro, es muy importante. Yo uso con mucha frecuencia, pero tú no necesitas usarlo siempre. Ok, por eso les enseñé también formas alternativas de operar sin el piezotomo. y no necesita siempre. Um, ok, Jurandir, um, nós vamos. Nós fizemos aqui, onde você viu que temos pessoas do mundo todo, né? Tínhamos que fazer em outra língua, ok? E eu já estava vendo com o meu time para a gente fazer uma legenda em português, tá bom? E também aqui no YouTube é possível também uma legenda automática, mas por favor fala com a Luciana, tá? Do nosso suporte, que ela pode te ajudar nisso. Ok, Uzbekistan, so amazing, thank you, Kamal, gracias, thank you very much. Miguel, gracias, saludos. Gracias, Miguel, gracias por la confianza siempre. What kind of sutures do you use? Nasal splint. Okay, nasal splint, I use nylon. Okay, use nylon suture. Yeah, one tip is don't squeeze the suture. Okay, leave it not so tight. If you leave it so tight, you can have a septal perforation. When you reinsert the Pitangui ligament to prevent bleeding or fibrosis in the supratip, to what anatomical part do you suture? What metro suture you use? Okay, I use PDS, Ruben. Very good question. I use 5.0 PDS and I suture. I try to create a little sling and suture in the front part of my septal extension graft. Okay? Because if you suture on the dorsum, sometimes you create a volume on the supratip and you don't want this volume. So when we create this little sling, you pull the ligament and on the direction of the extension graft. Gracias de Caracas, Diego. Ok, Diego, vamos colocar sim no grupo do WhatsApp. Oh, my friend from Thailand, thank you. Watching Algeria, thank you very much. México, ok. Paraguay, saludos. Gracias a usted, Demetrio. Ok, Thailand. Sí, yes, I know. Thank you. Yes, Alejandro. Tenemos fellow, ok? Tenemos fellow, visitor fellow y clinical fellow, ok? Por favor, clique en el enlace para hablar con Luciana, que tiene las informaciones sobre el fellow presencial, ok? Para que usted pueda venir acá y quedar con nosotros algunos días o por un año. La férula es o cintas en general 7 a 10 días. Ok. Ok, nasal splints already answered. Perú, gracias Perú. Siempre mucha gente de Perú, gracias. No, I don't use bailarina maneuver or lateral key area release in all cases, okay? I just use when I need to articulate or create this mobility between the cartilage and the dorsum. If I don't need it, I don't do, okay? From Yemen, thank you. Las suturas de los salares, sí, PDS 5.0. República Dominicana, sí, Yuderka, gracias, saludos. Gracias, gracias. Claro, Dorli. Hay un artículo de un gran cirujano acá de Brasil, doctor Manuel Pereira. Nosotros le vamos a enviar, ¿ok? Pero acá también yo les comenté el protocolo, pero claro, hay el artículo. Saludos de España. Y gracias. Sí, tenemos curso de fellow para residentes de cirugía. Gracias. Bueno, quedará acá por poco tiempo la charla en el YouTube, ¿ok? Can you do hump reduction to convert S to V shape, then preserve dorsum or let down? Yes, nowadays, my friend, Dr. Saad, you can reshape your dorsum and then preserve. Okay, so that's makes the indication of dorsal preservation very wide, and it increases a lot the chances for you to apply dorsal preservation. Okay, yes, you can do that. Okay, my friend from Thailand. Yes, we have longer programs. Okay, but so far we had 1 week program, visitor fellowship, or 6 months. Okay. Uh, Nicaragua, gracias, gracias, muchas gracias, Javier, gracias, muchas gracias, Javier. Eduardo, gracias, Eduardo, from Mexico. Syria, Ali, thank you very much. All right, so answered here all the questions. Thanks again, my friends. Just click on the link below, talk to my team, and it will be a huge pleasure to have you on board in our family of rhinoplasty lovers. And also, hope to see you face to face in one of our meetings or here in the fellowship program. Okay. Thank you so much and have an amazing evening, everybody. Thank you.